been part of the COMPASS study since before the grant writing. She was involved in some of the initial thinking and feedback to the clinicians here at Wake Forest, where her husband, a physician here at the medical center, was treated after his stroke. She is a retired middle school teacher, and she often credits her ability to advocate due to her position as a middle school teacher. She's been a very fierce advocate for Dr. Celestino during his recovery, and in particular while he was working through aphasia. So Joan has been heavily involved in training our post-acute care teams at the intervention sites, and she was such a hit that when the control sites switch over to implementing COMPASS, you will meet her in person as well. And she's also been very involved in developing the handouts that we have created for providers on communication, how to communicate with patients after they've suffered a stroke. And so one thing we have learned in sort of our listening to stakeholders throughout the study design is that everybody has a different perspective. And one thing that our stroke survivors highlighted very, very quickly was that currently the standard of care tends to forget family members and doesn't support them the way they need to be supported. They are sort of worn out in their caregiving duties. In many cases, they themselves are elderly or of poor health, and taking on the responsibility of caring for a spouse is tremendous. And it was our stroke survivors that brought our attention to family members much more clearly than family members did. Our family members were constantly focused on the patient's needs, and the patients were the ones that kept saying, "Don't forget my caregiver, don't forget my caregiver. It's actually in my best interest if you also support my caregiver." And so, Joan, why don't you just share briefly your thoughts on why it's so important to care? I know that you are a loud advocate for patients, but also for other caregivers across North Carolina. If you could highlight for all the members on the call why it's so important that we capture the caregiver's perspective in our survey as part of the study design.
Well, I think my husband and I had probably a different picture than some others. We were fairly healthy right at about 60 years old, and my husband coughed too hard, had bilateral dissection of his carotids, and they were happily able to save his life, but he did have a stroke. And from the point that happened, for quite a few months, even though he understood what was going on slowly, and he began to get his ability to move back, he was not able to control his rehabilitation. He had to have somebody strong who could see what was going on and move towards the determination that he could then produce. And so I think when we think about people with stroke being discharged from the hospital or from rehab, and they come home, their success is maybe at the very beginning totally in the hands of their caregivers, because the caregiver is the one who makes sure that the medicine regimen is followed. They make sure that they get to the rehab things they need to do. They need to be right there for them to make sure any physical practice or occupational therapy, the practice is done at home. So it's really at that beginning part, really for the first 3 months, it is totally who is driving the rehab. And that is something that is sometimes missed. Certainly, the patient should be the center of everything. But what happens is the patient often doesn't really know how to organize all of that. And so I think what's happening is there is a drop from the caregivers, from the hospital caregivers, between that and the actual family caregiver. Now, in our situation, I was teaching middle school. I was happily able to find a couple of sort of underemployed people in my church, and they came and were with my husband while he needed somebody 24/7, and then I came home from my job and continued it. But the determination to succeed really came from me. And so it is critical that anybody talking about stroke realizes that the support and the resources at the beginning need to be really fully behind the caregiver. And, you know, as we've gone along, my husband has now done wonderfully. He happily talks about his golf game approaching, at least he's under 90 now, and so he's very pleased with that. But the major thing is now he can have goals and drive that. But at the beginning, it was in my hands. So, Sabina, do you want me to?
Yeah, and so I know at the beginning he was told he wouldn't be playing golf again, and so you've come such a tremendous way. And I do want to highlight, this is something Joan has said herself, that she and her husband were in a unique position compared to most families, and that they were highly educated and had high income and access to resources that most people probably didn't have. And despite those advantages, it's a tremendous burden to overcome. And one last person who has said this to me is the Betsy Vetter, who's the head of governmental affairs for the American Heart Association here in North Carolina. And she is probably one of the most resourced, knowledgeable people around stroke. And when she was faced with having to care for her husband after his stroke, she said she was completely overwhelmed. And so you have these highly motivated, highly engaged, highly resourced individuals who are overwhelmed. And so when you consider the average family, the burden can truly seem overwhelming.
And you mentioned this before, but also the health of the caregiver, in addition to the health of the patient, is terrifically important.
Yes, and so this is why when we intervene through the Compass intervention, an element of assessing comprehensively how the patient is doing is pivoting to the caregiver and going through a battery of questions with them to understand what their needs are to care for the patient, because just exactly as you said, Joan, they're really driving rehab initially.
Joan, do you have any other thoughts you want to share about the importance of having the nurses and the hospital staff, touch base with the caregivers?
Well, I think that stroke is a devastating condition, and to recover from it requires a tremendous amount of hope and determination. And it is always everybody's goal to infuse that into the stroke survivor. But it is critical that somebody help get that into the caregiver as well. And I think that the medical community is much, is really too afraid to give hope. And I think that it's the only way caregivers can go on is if they think there is hope. And so they need to understand where somebody might be able to move and how they will be able to move forward. And also the idea that improvement after stroke can go on for years and years and years. So my husband is now 4.5 years out, and he has pretty good movement, but his hand was still a little bent. Well, he decided he'd go to acupuncture. And, that's now improved. And at each stage, we visit people and they say, oh, you are so much better than you were last year. So his attitude is his attitude of what he can do and how it will be in the future is totally defined by the recognition that improvement continues. And so I think that that's a critical aspect of dealing with the stroke survivors, but also with the caregivers themselves.
One thing we do wanted to highlight, right, was that it's necessary to get the caregiver survey completed, because what makes Compass unusual is that it's assessing the needs of the family member caring for the patient in addition to the patient. And so we want, it's our secondary outcome, that we've reduced family strain through the Compass intervention. And so it's absolutely important that we get the surveys that we're mailing out to patients across the state, to the families across the state, returned to us in a higher rate than has happened so far. But we should turn the phone over to Barb, too.
Hi, everybody. I'm glad to be on the call. I've been involved in Compass since it got funded, and have done a lot of work around caregivers and the importance of assessing not only the patient but the caregivers. So that's what we just wanted to talk to you briefly about today, on top of what Joan has already shared with you. So next slide. So as Sabina just said, in addition to the focus on the stroke survivors and the outcomes that we're looking at for the stroke survivors, we're also looking at outcomes related to caregivers, particularly around strain or burden. And so in the intervention, we do have some mechanisms to provide some support to the caregivers through providing resources and information on the Compass website. And then at the end, at the 90 days, we do an assessment of what kind of caregiving they're doing, and then do this caregiver strain index, and that's the survey that gets sent out at 90 days. Next slide, please. So the caregivers are contacted by Compass personnel when the patient's discharged to try to get reliable contact information and their relationship to the patient. And so that's something that we hope you all are able to do, is to get us the most reliable information you can related to that. We know sometimes those people change, like you might have an adult daughter that's providing care, and then maybe as the patient gets a little better, then maybe the spouse can take over, or maybe there's not somebody that's doing much of the care anymore. But we'd really like to try to capture as many of these as we can, and as Sabina mentioned, our rates of capture haven't been as good as we had hoped. So again, that's one of the things we wanted to kind of stress so that you can understand the importance of that. Next slide, please. So the questionnaire that we send at 90 days gets some just demographic kinds of information related to the caregivers, and then it does, we do a brief assessment of the care they're providing and the amount and of time and frequency of their post-stroke caregiving, and then we do this standardized caregiver strain index. Okay, the next slide. And if you can hear that phone in the background, I apologize. So this just gives you, if you can see this, for those of you who can see this, it provides a list of the kinds of things that caregivers may be required to do once the patient goes home. So we ask if they're helping, We ask if they need assistance with that, and then we ask also if this was something they were doing prior to stroke, because we got some feedback from some of the caregivers that this was not a new task for them. They had always helped with driving, or they'd always helped with preparing meals or the housework or whatever. So so we wanted to make sure that we were able to separate that out. So this is the survey that gets sent out. This is part of it. And then next slide. Then this is the Caregiver Strain Index. This is a standardized tool that is available. It's a validated tool, and I think it's about 12 or 15 items. It's pretty easy for them to fill out, and like I said, it's been validated in studies with stroke patients before. So this is what we're asking them again to complete, and when they get that 90-day questionnaire. Next slide. So as Sabina mentioned, we've had a really low response rate, and so we're really trying to figure out some mechanisms to try to improve that, especially with the usual care sites, because we have such limited contact both with the stroke survivors and their caregivers. And so we think some of these are potential explanations, that the caregivers don't think that this pertains to them, that if the patient doesn't have a lot of functional limitations and they don't require extensive or long-term caregiving, then the caregiver may think, well, I don't need to fill this out because it's not applicable. Or that they were providing similar care before the stroke and now after, and so they think, well, this isn't any different, so why would I fill this out? Or again, as the caregivers may change over from the time of discharge to when we send the follow-up. So next slide. What we're really interested in is any ideas you can give us to try to better get these, try to engage these caregivers, or things you can think about to make sure that you really connect with them before they're discharged, so that when we send the 90-day survey, we do get it back. And you can also emphasize the importance, reminding them that they will be getting this, and would they please send it back in, or tell the patients, if they're able to understand, that this survey will be coming out, and could they please encourage the caregivers to complete it for us. So I'm hoping some of you will also have some suggestions about how we can better capture this, get the caregivers to complete this tool.
So I think we'll go ahead and move on into the second part of our webinar that Rika and I will be providing on supporting our caregivers. And Rika, next slide. So we just talked quite a bit about the Caregiver Survey that is done somewhere around that 90-day period. But we also want to talk about the Stroke Caregiver Assessment, that one that is triggered at the post-acute functional assessment. Next slide, please. So let's just differentiate just a little bit. So the Caregiver Survey, as we've just noted, that is completed in both the usual care and the intervention arms, and that's the survey that's mailed at around 90 days. And the caregiver does get a letter letting them know that this is going to be coming. In fact, they get a couple of letters, and then this gets mailed out. The Stroke Caregiver Assessment is completed in the intervention arm only. And once again, it is completed at the clinic visit, when you all are doing the post-acute functional assessment. If it gets triggered, you all know that you complete the caregiver assessment if the caregiver is there. And the responses that we get from the caregiver assessment really do help us inform the e-care plan and generate all of these wonderful community resources for caregivers. And it could be directly or indirectly. We could identify the need for respite care or adult daycare or various other services that the patient may get, but the caregiver also benefits.
So really, really important if this gets triggered to complete the caregiver assessment and then use that information to build the e-care plan on behalf of the patient and the caregiver. Next slide, please, Rika. So again, for the purposes of today, for this part that Rika and I are doing, we're going to focus on the stroke caregiver assessment that's completed at the clinic visit. And next slide, please. So just a few facts, and these won't surprise you at all, but just a few statistics. You can, if you're able to see the webinar, and I know some of you aren't, you can see the statistics, but for those of you who are listening only, I am going to go over them for you. But, you know, this won't surprise you at all. We hear this all the time from caregivers. You know, when the patient's life changed on a dime, went from normal to, in some cases, very abnormal as to what they were used to, then the caregivers does as well. And they do report having trouble finding enough time for themselves and managing their own emotional and physical stress. They also have trouble balancing work and family responsibilities. And I'll give you a case in point, and I'm sure you can, if you think about your own patient and caregiver population, you'll think of your own cases. But one right here in Winston-Salem, a patient and caregiver that we've been working with at the Vanguard site at Wake Forest Baptist Medical Center, is the story of a 51-year-old man who was moving along with his career nicely. His wife was moving along with her career nicely, traveling quite a bit. The wife was, and the husband was the person to sort of stay home and hold down the fort and help with the two teenage kids. And they were together one evening. The wife was out of town. And fortunately, one of the teenagers recognized that something was very wrong with his father and called 911. And sure enough, this man was having a big, bad stroke that left him aphasic, and I can't remember if it's left-sided or right-sided, serious weakness and inability to ambulate. And the wife comes back into town. You know, she left him normal. The family was normal. Everything was going great. And all of a sudden, the whole 4-person nuclear unit, their lives have changed on a dime. So when that happens, oftentimes because we love our loved ones, the patient, so much, we begin to sacrifice a lot about ourselves in order to take care of our loved ones. And this can come, you know, in the shape of sacrificing time, attention, our own medications, our own doctor's appointments, and so on and so forth. So it's why it's really, really important for us to ask the caregivers. You know, sometimes we learn from caregivers, and we oftentimes learn from patients too. You know, no one ever asked my wife, no one ever asked my husband, no one ever asked my kids how this is impacting them and how they're doing until I brought it up. So we don't want to be in a situation like that where we are waiting on the patient to take care of the caregiver. You know, we should be asking them during these important assessments so that we can provide them the help and the support that they need. They also report that they need some help keeping the person that they care for safe. This is where, you know, we can call in community resources like falls prevention or adult daycare, community-based physical activity programs like the YMCA, and so on and so forth, because they're also oftentimes looking to find easy activities to do with the person that they're taking care of. And they're not sure. You know, all of a sudden they become a caregiver with sometimes zero experience with that. So all of this leads to a lot of additional stress and strain. And if the truth be known, and if people are honest with us, sometimes tell us even burdensome, but they don't want to say that in front of the patient because, you know, they feel like the patient might feel guilty. And of course, this is no one's fault, but half of the caregivers, or over half, say that their health has gotten worse due to their caregiving, and their own health has begun to decline, and this affects their ability to take care of their loved ones. So again, increased stress and strain because of the increased workload and burdens. They might not go to their own doctor for various reasons. First of all, as one of our team members just said during another part of the webinar, they simply don't have time. They are overloaded, or they don't feel like they can make time. It's hard enough. It's like a 36-hour day. It's hard enough trying to get all the patients' needs taken care of, and theirs just falls to the wayside, and sometimes until they get to the breaking point. So, you know, this, I know once in a while I'm in clinic just as a reminder of, you know, what's out there with the patient and caregiver population. I know why I do what I do. It's not just professional, but it's personal. But I like to get into clinic once in a while to see these patients and caregivers and hear what they have to say to our post-acute coordinator, Gail, here, and our two awesome APPs, Christina and Sarah. And sometimes when I'm in clinic, it's hard for me to tell until the patient is identified which one's the patient and which one's the caregiver. And the last time I was in clinic, it's been a little while back, but an older gentleman came into the room pushing an older woman in the wheelchair, and honestly it was difficult to tell which was which, but the patient was actually pushing the caregiver in the wheelchair, and the patient was able to ambulate but didn't have the cognitive skills, and the wife in the wheelchair was the one with the cognitive skills to talk about medicine, other pieces of the plan of care. So I just really encourage you, as you're working with your patients and caregivers, to not forget about the caregiver. Make sure that you're doing proper assessments of them and helping them all find their way forward to better health, independence, and recovery. And I'd like to stop there and turn over to Rika, who's going to talk about the actual caregiver assessment itself, and then we'll have time at the end for questions.
Thanks, Sylvia. So just the bigger question, why do we perform the caregiver assessment in the clinic visit? And it's because it's important that we assess the well-being of the caregiver, since the caregiver does play an important role in the patient's recovery. So if you look at the slide, these are just some of the questions that we do ask the caregiver if a caregiver is identified. Is the caregiver stressed? Does the caregiver have any other competing demands, any health issues? Is a caregiver a willing and able caregiver? And that is an opinion from the advanced practice provider. But we also want to know if the caregiver can identify two of the patient's medications and also explain why that patient is taking the medications. And we do go through a list where we ask the caregiver what do they assist with, such as bathing and feeding, household chores, and do they need additional help with that. And so a lot of the questions that we get from the PACs is, how does the caregiver assessment get triggered? So the caregiver assessment gets triggered from the post-stroke functional assessment. So how do you know if it got triggered? So if you're there on the post-stroke functional assessment, you're on the last question, and you hit next, save, and finalize, the caregiver assessment should flow right after that stroke functional assessment. That means the caregiver assessment got triggered, and we would like for you to perform that caregiver assessment. So there may be times where you are performing the post-stroke functional assessment with the patient. You're on the last question, and you hit next and save and finalize, and it goes back to the dashboard. So if it goes back to the dashboard after the stroke functional assessment, that means the caregiver assessment was not triggered, and you actually don't need to perform the caregiver assessment. We only want you to perform this caregiver assessment if it actually flows directly from the stroke functional assessment without going back to the dashboard. So there are 3 questions from the post-stroke functional assessment that does trigger that caregiver assessment. And if you look here on the slides, these are the actual 3 questions. The first one is, can you prepare your own meals and do your own housework without any assistance? The second one, can you bathe or take a shower and dress yourself without any assistance? And the third one, does someone help you manage your medication? So if the patient responds, yes, someone does help me prepare my meals, or someone does have to help me bathe and dress myself, and someone is managing my medications, then that means the caregiver assessment will get triggered. And if you look here at the slide at the asterisk, this is just something I want you to just take note of. So those questions all don't need to be answered negatively in order for the caregiver assessment to get triggered. So what I mean by that is, if you look at number 1, if the patient is able to prepare their own meals, and then number 2, the patient is able to bathe and dress themselves. But if you look at number 3, if the only thing this patient has help with is managing the medications, the caregiver assessment will still get triggered. So one of those questions have to have some kind of caregiver assistant with it, not all the questions together. And so we have been receiving a lot of feedback from our hospitals after they have launched the COMPASS model. And if you look here on the left-hand side, I did put different quotes or scenarios of just some things that we do get back from the PACs and the APPs. And if you look at the first quote on this first scenario, the patient is independent in ADLs and IADLs. The only thing the wife is doing is managing his medications and putting them in a pill box. Why do I still have to perform the caregiver assessment? So that is just one scenario that Sylvia and I get questions on. And the next one is the patient is completely independent. Yes, the husband has to help more with household chores, but the patient is perfectly fine. The caregiver assessment wasn't necessary to perform. So that's just a gist or summary of the feedback Sylvia and I get. And so if you look on the right-hand side, there's just some things just to remember and consider. Number 1, even if the caregiver only manages the medications, and this is based from the first quote, this may be the only thing that the caregiver does, is just managing the medications, putting them in a pill box, buying the medications from the pharmacist. Even though that's the only thing the caregiver does, well, we still need to know, does the caregiver have a knowledge of those medications? Does the caregiver know those medications, and do they know why the patient is taking them? We want to make sure that if the caregiver is performing this task, that they have a strong health literacy in the medications. And if you look at number 2, the caregiver may only be performing additional household chores, but we want to perform this caregiver assessment because we want to see if that caregiver has excellent help to even carry on this additional task. And we don't even know if the caregiver has additional health problems, or if there's other competing demands that prevents them from even doing this small additional task. And then number 3, the reason we want to perform this caregiver assessment, even though the patient may only need assistance in the smallest things, we want to make sure if does the caregiver have a full-time job that interferes with the ability to care for the patient? Is the patient or is the caregiver well? Do they have good health? So just keep that in mind for things to consider, because the feedback that Sylvia and I get is, we really don't feel like the caregiver assessment is necessary because the patient can perfectly take care of himself or herself, and that's okay. But even the smallest things that the patient needs help with, we still want to perform the caregiver assessment because we don't know what the caregiver is going through unless we ask the caregiver themselves. So this is just some things I don't want you to forget. So if you look here on this slide, just remember that a secondary aim of the study is to assess the burden, stress, and strain on the caregiver. So this is why we do want this caregiver assessment, because not only from a clinical standpoint to take care of the caregiver, but also from a research standpoint as well, so we can analyze that data. But also completing that stroke caregiver assessment, it will allow us to see how our caregiver's age, work-life balance, or sex, or their health rating are indicators of his or her ability to take care of the patient. But most importantly, when you perform this caregiver assessment, the eCare plan will provide additional resources for that caregiver. So if the caregiver is stressed, we will provide a resource for them. If they're in poor health, if they need additional assistance, maybe through the PACE program, we will provide them help. So that is why it's important that we perform the caregiver assessment. And so this next slide, a lot of the feedback that Sylvia and I and Christina get is that we, how do we introduce the stroke caregiver assessment to the caregiver? We completed the stroke functional assessment, but how do we do that transition, or how do we do that introduction of moving to the caregiver and performing this assessment? So there is this little snippet of a quote that you can definitely use, or you can just jazz it up and put your own input into it, but this is just a way for you to introduce the assessment, the stroke caregiver assessment, to the caregiver. And you can say something like, since you are the primary caregiver, I would like to ask you a few questions just to see how you have been doing and to see what additional resources are available that may help and support you and your loved one, because we care for the both of you. So that is just a way for you to introduce the caregiver assessment to the caregiver without it sounding awkward, because the feedback we get is that it can seem sort of awkward. So I didn't know if Christina, I think Christina's on the line. I don't know if she came in from clinic or not, but if Christina and Sylvia have anything to say about introducing the caregiver assessment.
Thanks, Rika. Yeah, sorry I'm late. I was actually in clinic, and it's interesting because I had a patient who had a stroke, and then come to find out the wife had a stroke like 3 months ago. So now I'm like at an outside hospital, so now they both have had strokes, you know, and so I mean, this is such the reality. And then it's really pertinent because, you know, these are things that happen, and as far as these caregivers, they're sick themselves. So we were able to get these patients services, both of them actually, community services for both of their stroke needs. The other thing I think we run into is sometimes the spouses have to leave their jobs to take care of, or they had insurance issues. So these were, today I had to deal with this as well, as trying to help the wife be able to get to financial counseling or a social worker or something to work out the insurance issues and her job. So I do think introducing a caregiver assessment in a way that says this isn't just more paperwork, this is something that we are going to try to help you. We'll be here to, you know, maybe you don't have any questions now, but in the future we can help coordinate any needs or resources, and so this is just not more paperwork for you, but it's really going to implement something. It's actually going to help. And so because they just don't want to fill out more forms, and sometimes we even bring them into a different room. If we have time and if clinic space allows, we can bring them the caregiver so that they can be honest and open and not feel the caregiver, the burden the patient feels. It's hard to talk about sometimes. So those are just my 2 cents.
Thanks, Christina. That's really helpful. And I think, you know, what Rika presented and then what Christina has said are some really great takeaways for you all. And just again, letting the caregiver know that they're not, you know, they're not taking a huge backseat, that they're important to you too, that they really are important. And like Christina said, it's not just more questions, more paperwork. It really is to inform that care plan that's for the patient primarily, of course, but is also for them to help get them, the both of them or the family unit in some cases, the resources that they need for everyone to move successfully forward.